seniors, teachers and colleagues. I am with the side of empagliflozin in this small debate. Will I switch over to empagliflozin? We all know that almost 37 companies with more than 200 products have bombarded your OP once the patent of empagliflozin got over. Is there any real difference between these molecules justifying the hype? That is the question. We'll look at these headings, pharmacokinetics and trials and the safety outcome, to decide whether we will switch over to empagliflozin. So starting with the pharmacokinetics of SGLT2, if you look at empagliflozin, it has got the maximum SGLT2 selectivity among the gliflozins. Along with the low lipophilicity and the tissue distribution, it acts primarily on the organ it is meant to act, that is the PCT of kidney. So it has less side effects and it produces more superior glucometabolic benefits, as like reduction in HbA1c, reduction in fasting blood glucose, weight loss and systolic BP. This is the theory part. Whether this has been converted to practical data, we will go through the trials. The first group is the cardiovascular outcome trials, whether when the patients have diabetes and established atherosclerotic cardiovascular disease or high risk cardiovascular risk, we will look into the CVOT trials. We know that the flag bearer of CVOT trials is the EMPA-REG outcome, which used empagliflozin in patients with diabetes and established atherosclerotic cardiovascular disease. Almost 7,000 patients were followed up for 3 years and looked upon the 3-point major adverse cardiac event that included cardiovascular death, non-fatal MI and non-fatal stroke. It has been shown that there was 14% relative risk reduction in 3-point major adverse cardiac events, and this is mainly driven by the reduction in cardiovascular death. If you look at the reduction in percentage, there was about 38% relative risk reduction in cardiovascular death. If you take the Asian subgroup, in this group, there was additional 56% relative risk reduction. And this risk reduction of 38% have come from the hard endpoints like reduction in fatal MI, fatal stroke, sudden death and presumed sudden death, and more from heart failure related death. So when you compare this with a CVOT of dapagliflozin, that is declared MI, even though it produced a composite reduction of heart failure and cardiovascular death, the major adverse cardiac event didn't offer as much significance as we got found out in EMPA-REG outcome. This has prompted all the guidelines to include empagliflozin under the heading of reduction of major adverse cardiac event. This is the recent ADA guidelines 2025. If you look at the column of effect on major adverse cardiac event, you can see that only canagliflozin and empagliflozin is included in the column of reduction on major adverse cardiac events. But if you look at heart failure and progression of kidney, both EMPA and DAPA are included. So we'll go on to the heart failure trials, whether is there any difference between EMPA and DAPA. If you look at the heart failure trials, we know that the Emperor reduced and the Emperor preserved is the main empagliflozin trial, which almost looked at 10,000 patients, and they looked at the time to first cardiovascular death or heart failure hospitalization in heart failure patient. And EMPA has shown that in all group of heart failure, whether it is a low ejection fraction, high ejection fraction or a medium range ejection fraction, it has shown a high relative risk reduction of heart failure hospitalization and cardiovascular death. What does it mean? If you look at the heart failure with reduced ejection fraction alone, the recent trials like DAPA heart failure, the paradigm heart failure which used the ARNI, if you look at the rate of reduction of absolute event rate, it was much better for when the empagliflozin was used in Emperor reduced. More than that, this has shown that not only the heart failure reduction, but the heart clinical endpoints like the initiation of dialysis, renal death or sustained reduction of eGFR more than 40% was much better when empagliflozin was used compared to DAPA and paradigm heart failure. What is the most important thing that we have learned from this trial? The effects start much earlier. If you use empagliflozin in heart failure with reduced ejection fraction, the effect starts appearing at the end of 12 days. In preserved, it starts appearing at the 18 days. Whereas in DAPA and other gliflozin, it usually starts 4 to 8 weeks. This is the most important point to look after when you are prescribing in heart failure treatment. And this has been shown that almost 50% of the heart failure patients have some amount of CKD. And in all the group of CKD patients, whether it is a normoalbuminuric patient or a overt albuminuria of 300 milligram per gram, there is significant heart failure reduction and cardiovascular death. So, is there any data in acute heart failure? There are few studies, one among such is Impulse, which show that at the end of 90 days, 36% of the patient had significant clinical benefit when you start empagliflozin early in acute heart failure. So, moving on to CKD trials, we have finished major adverse cardiac events, we have finished heart failure. Let us look into CKD trials. Even the EMBAREG outcome, which is a cardiovascular outcome trial, has shown that the incidence of worsening nephropathy, progression of microalbuminuria or doubling of serocreatinine and initiation of dialysis was reduced by empagliflozin. Is there any heart trial in CKD? One trial is EMBA-Kidney, which is the largest and the most inclusive SGLT2 inhibitor trial till date. The importance of this is that it has included a lot of variety of patients, more than that other trials have included. It had 50% diabetic patients, but other 50% were primary kidney diseases or hypertensive renal diseases, and all these groups, irrespective of diabetes status or irrespective of GFR, it has shown that there is significant reduction of progression of kidney disease or heart disease. In MI, acute MI patients also, when empagliflozin is initiated, it has shown that the first incidence of heart failure admission has been decreased by empagliflozin, not by other gliflozins. Safety outcomes, there is not much difference between the gliflozins. If you look at the summary, genital infections was much higher in empagliflozin, but the incidence of UTI was much higher in dapagliflozin. If you look at orthostatic hypertension, there is a slight increase in orthostatic hypertension in empagliflozin group, but it is mostly due to the decongestive or the diuretic effect of empagliflozin. So, in summary, empagliflozin is preferred because of its strong cardiovascular mortality benefit, its wider use in heart failure and the early benefit, the wider and broad range of usability in CKD, the better metabolic outcome and safety profile. Thank you.